Welcome everyone who's joining. We'll start in about less than a minute. So folks are coming on in, and good morning, good afternoon, wherever you're from. Okay, I think that we'll get started. Welcome to ReelDx Classroom. I'm Dr. David Spiro, the Chief Medical Officer of ReelDx. It's awesome to get to spend time with you all today. We're very, very, very honored to present this with our partners, POCN and Smarty Pants, to bring this amazing educational experience to your home today and classroom, wherever you're learning from. And I'm incredibly delighted to have Joe Gilboy with us, who is an outstanding educator himself. He went to college at the University of Virginia, is a physician assistant himself, is working in the California system, has decades of experience, both as a clinician and as an outstanding educator. And we are incredibly fortunate to have him here. This is our second experience working with him in this setting. Joe, welcome and good morning.
Good morning, good morning, good morning. Well, good morning, everybody out there. So we have a couple cases here we need to go over. And what we're going to do is we're going to go over each case. And the way we're going to do it is we're going to go over the cases. And obviously, if you have any questions along the way, please put them in the chat room and we will definitely, or in the question and answer part, and we'll definitely address them as they come along. And then what we're going to do is we're going to go back. I actually made a PowerPoint on both of these cases and to go back and kind of redigest them because there's some really great clinical pearl stuff there that we need to continue with. So in other words, these are things that I think are really beneficial here. So let's just kind of jump into it, guys, here. So this is our first case here. So what I'm going to do is I'm going to play the video here on this individual here, and hopefully you guys can see this, and then we can go ahead and discuss this afterwards here and stuff like that. Okay, guys, so here we go.
Feeling right now?
I'm feeling better than I did when I got here.
Gotcha. Do you remember what happened? What brought you into yesterday?
Yes, I was at my son's house, and I was going home I live next door to him, and I was going home to make lunch and then take a nap. So I went out. I usually go out his back door because there's my mother, yeah. I'm sorry.
That's fine. There's like a slanted, right? Yeah. There's like a porch. So it seemed like you got from his house to your house and you were in the driveway.
I went out of his house, went down his driveway, which is that stone stuff, and I was walking with my cane, and I got to the road, and then I live to the left of him, and I turned, and all of a sudden I just lost control, and I fell backward, and I couldn't stop myself, and I woke up with my neighbor standing over me. He had just come from our downtown. He is a fireman. And he heard the plectron and it said my name.
Okay.
And then he saw me, and he stopped, and he helped me to he saw that I was bleeding. He helped me to get up. But he wouldn't let me move.
Yeah.
When he saw he told me I was bleeding, I didn't even know it.
Yeah. Yeah, he did the right thing.
Oh, he
And-
did.
yeah.
He did.
And it seemed like he called ambulance right away, and he got you here.
Well, he called my son. He went.
Okay.
Actually went to the house
Uh
to
huh.
get Todd to come out.
So I'd like to stop it. Joe, do you want to talk a little bit about just the concept of sick or not sick? This is a long interview and
Right. No,
lots
it's a very
lots of
long
things.
interview. So I think we can all agree that, her answers are very pretty much discombobulated. So this is definitely what we'd all consider an altered mental status. There she is talking about, leaving the house and going down the steps. And then she's talking about her mom. So we can all agree just from an outside point of view that, sick or not sick. So she's definitely sick. She has something going on here. And I think the key point is that, she's having a hard time just answering just kind of simple questions like, okay, so what happened? Walking out the back steps. I got this. And then she's searching for thoughts, is what she's doing. So that's the big thing here to take away, guys, is that this is not someone that we're having a normal conversation like in your kitchen and having a cup of coffee with. This is someone who's really searching for words. So I think at this point we can all agree that she's got some type of altered mental status at this time. So I think that's the take-home message to this part of the video here right now.
And we did talk about it early on for those that are attending this, but please be interactive. This is not a unilateral chat between Joe and I and Joe leading this discussion. We want your questions. So please type in the question and answer, and we'll get to your questions as we go along. So I'll continue to play this video.
Help me. And
Yeah.
yeah, they called the ambulance.
Okay. So just prior to this fall, do you remember having any headache at all?
I don't.
Anything?
I've
No.
had problems with my blood pressure. It had been 200, over 200 that week. And I went to the emergency room
Uh-huh.
at our local hospital.
Uh-huh.
And
Okay.
my doctor doubled my medication.
Uh-huh.
So
Yeah. Had you been having any headaches over the past week?
I haven't had any.
No. Any trouble with your vision?
No.
No.
I haven't had any trouble with my vision.
Yeah. And just prior to this fall, did you have any chest pain, any abdominal pain?
No.
Felt you couldn't breathe?
No, I had been in the house talking to my son.
Gotcha. Yeah.
I was fine.
Any chance you can have been like dehydrated or anything? Had you had your lunch and breakfast that day or no?
I was going home to have lunch.
Okay.
And I did have breakfast.
Oh, you did have breakfast. So it's not like you were feeling sick or you were not feeling good that day, right?
Well, I was not feeling the greatest because the whole week I've been with
Yeah.
blood pressure.
Okay. So when you say you were having blood pressure issues, what were you feeling? Like, how did you know your blood pressure was high? Like, what were you feeling like over the week that you think was like wrong with you?
Well, for one thing, nurses were popping in on me.
Uh-huh.
Our town nurse,
Oh, okay.
they were checking on me.
Yeah.
And
Yeah.
so it was just a different
Yeah.
kind of
Yeah.
week.
Yeah. Yeah.
Um,
Do you remember like after the fall or like just before the fall, did you throw up at all? Were you?
no, I didn't.
No. Were you feeling nauseous?
No.
No.
At least I can't remember it.
Yeah. Yeah. And when you initially came into the emergency department, do you remember how you were feeling? You came in yesterday.
Oh, I did.
Yeah. So do you remember how you were feeling when you came in?
Well, when I came in, I was glad to get here because
Yeah.
I was very nervous.
Yeah.
And I was discombobulated.
Yeah. Yeah. Yeah.
I but just didn't know what was going to happen with me.
Yeah.
I
Yeah.
really thought that I was
Yeah.
goner.
Yeah. But it seems like now you're feeling good, right? I'm so glad you're feeling better. Just some quick things. When I ask you, just going to do a small, quick neuro exam. Can you close your eyes and open your eyes for me? Perfect. Can you blow your mouth?
Well, I know.
Blow your mouth. Perfect. And just some silly questions. Do you know what month and date is this?
It's October 27, 2020.
Perfect. All right. And who's the president of United States?
Trump.
Perfect. All right. Just some quick things. Can you give me a nice smile? Perfect. All right. Clench your teeth together. Clench your teeth. Perfect. All right. Can you put your arms up in the air for me? Oh, I'm sorry. I'll help you with this. All right. Both your arms up in the air, like straight in front of you, with palms up, like straight up, like right here, and with palms up. The other one as well. Perfect. All right. You can relax. You can relax your arms. You're good. You can relax. Yeah. You're all good. All right. I'm so glad that you're feeling good now. Okay?
Thank you.
All right, Joe, you're on mute. You're still on mute.
Okay, there we go. All right. All right, guys. So let's just kind of go over the basics. So she's an 88-year-old female. So there's her vital signs, right? Got the temp 98.4, heart rate 103, right? I mean, you call that sinus tach by definition, but you come to the ER, we don't call that sinus tach, right? We just say just a little bit above 100, right? Respiratory rate of 16, pulse ox 97% on room air. So right now, right, these are your vital signs, and there's her blood pressure 210/92. So I think we can all agree, right, that's a little bit elevated. So she's got this fall, got this loss of consciousness, and now she's got this headache. And then we can agree, right, that she's got somewhat, some mild altered mental status, right? Since she's kind of searching for words and things. So there's her medical history. She's got the type 2 diabetes. She's got chronic kidney disease, which kind of goes along with the diabetes, coronary disease. And there's the big one. There's the poorly controlled hypertension. I think we can look at the blood pressure and all agree to that. And then she's retired, non-smoker, lives alone, lives close to her son's house. Dave, can you pull the screen down a smidge there, bud? And then she's on aspirin. So she is on a blood thinner. And she's on levothyroxine. She's on metoprolol, beta blocker. There she's on the spironolactone and a multivitamin. So now you have to kind of pull back from ER setting. And I would say ER medicine, it's not that it's what's the word used? I think Dave said it best, sick or not sick. So I think we can all agree that this lady's got something going on. So she's sick. So now we need to work her up. So the question is like, so what do you think's in front of you? And so right now, this could be like a traumatic ischemic stroke. This could be a subdural bleed. This could be an aneurysm. She could have had syncope, because you see, this is the big thing. One of the things I've learned in my 37 years in the ER is when you have old people falling down, can they fall down due to balance issues? Yes, of course. I mean, we all fall down due to balance issues. So that's quite a given. But I think the thing that most of us need to kind of leave with this patient is realizing that when you have old people falling down, I always say, don't write it off as mechanical. You need to write it off as something else. In other words, it's syncopal. So in other words, is this a cardiac event? Is this a vascular event to the brain event? So in other words, we need to work this up. And this is why sometimes in that differential diagnosis, when you have these elderly people falling down, we tend to work them up pretty aggressively in the emergency room. So she could have a traumatic, intracranial hemorrhage. Obviously, this could be a bleed. This could be an ischemic stroke. This could be some type of aneurysm that ruptured here and stuff like that. And can you pull the page down just a little bit there for me, Dave? Thank you. And so now we do the full set of labs, type and screen, coags. All right, so now I want you guys to think for a second. So this is that moment where I want you to think. I'm going to stop talking and you're going to start thinking in your head. So just in the question and answer thing. So there you are in the ER. This is your patient. So there it is. I'm going to give you coags, glucose, EKG, CT, head and spine. And remember, when they fall, we always do the head and spine together. That's kind of peanut butter and jelly. And so my question to you, of all those ones, and I'm going to let you pick two, just two. Which two would you like to get now? So in your question and answer, give me two answers. So of all those, right? So I'm giving you type and screen, coag, point of care, glucose, EKG, CT, head and spine. Which one do you want to do first, guys? So give me your thoughts here, guys. Anybody wants to type in, I'm gonna let you. I'll give you a minute here, so give it a thought. And I hope most of you people are out there thinking to yourself, going, "All right, so if I got this person." Right. And Maria, you're 150% correct. I would get the EKG and the CT for sure. Because the coax, I mean, they're going to help. The point of care glucose, I mean, we can agree she's not hypoglycemic at this moment. She's making a lot of good sense. So I agree with you. So I'd get the EKG and the CT. This is what I would do. I'd be running this lady off to the scanner. I would have one of my, ER techs getting, quick EKG on this lady. And this is what I would look for, specifically with someone at this age and this kind of mechanism of fall. So if we just scroll down the page a little bit farther there, Dave. So if we just keep scrolling down the page.
I can ask a question because I'm a pediatric ER doc, and so
Yeah.
these cases are always interesting to me because I take care of the other end, not
right.
elderly.
Yes,
So
you do.
8 years old, and I'm always paying attention to vital signs, and her heart rate is 103, and her blood pressure is obviously very high, 210/92. The diastolic is a little bit less concerning than the systolic.
Systolic, correct.
And the other thing about this case and the vital signs playing into some of our review that you just went through is that she's also on a beta blocker, metoprolol, and her heart rate is 103. So I'm just like, I always try to figure out with my kids in the ER, I try to correlate what I'm seeing in front of me to what the vital signs are. And if they don't make sense, I'll just repeat them. And if they still don't make sense, then I'm thinking, do I need to add other things in the differential diagnosis or whatever? So I'm curious, you walk into this room as an experienced clinician and you see those vital signs. Are you worried? Does it make you more anxious? Does it make you think this patient's more sick? Like, how do you interpret the heart rate and the blood pressure in this?
Yeah. So the blood pressure, that'd be the first thing that'd be on our radar in the ER is that, right? Because she's got definitely the systolic pressure that we cannot let this sit here, right? So we're going to have to intervene really quickly to bring this down. The heart rate, I think, yeah, how do I say this? With adults, it's a little different in the sense that they can be on the beta blocker, and then they're on the ER. They could be like a little anxious and stuff like that. But I agree with you 100%. I totally get your logic 100%. She's on a beta blocker with an elevated heart rate. Totally agree with you 100%. So again, for our setting, we're going to look at this going, okay, this is possible, but we're also going to, it's not that we're going to wash it away. We're going to go, well, she could be anxious. She could be in pain. These are all things that would cause, your heart rate to go up. But I agree with you to tie it together, to morph it into, a clinical picture. Oh, I think that's a brilliant point in the sense that she's on metoprolol with a, a heart rate of 103. I can say from our experience sakes, when people are in pain, like when you see kidney stone patients who are on beta blockers, trust me, their heart rate's up. They're up. But again, it's putting the whole picture together, right? That's kind of the thing that I always like to try to do.
Assuming she's compliant with her medication.
Oh goodness! Oh, that's a whole nother universe. Oh goodness gracious! we're having another discussion.
But certainly a blood pressure like that, we're worried because of the potential of things that could cause high blood pressure. And
Correct. Yeah. Correct.
Sorry,
I
thought that was an important point to make. I as a physician always want to try to correlate the vital signs to the patient.
Correct. No, I agree with you 100%. Like I said, it's putting pieces of the picture together. Totally agree. Okay, so most of you guys chose CT and EKG, and I totally agree with you guys. That was a good move. So here's her outcome. So if you look here, guys, she's got some subarachnoid hemorrhages here in the frontal lobe here, guys. So, and this kind of correlates well with what happened. So does everybody see the soft tissue swelling in the back? Does everybody see there's that little soft tissue? So this is where she hit, right? That was that back of the head injury. So she does have a subarachnoid hemorrhage, is what she does. And this makes sense because this lady showed up, your frontal cortex, that's where you and I think, right? And so she can't think, right? In other words, she was lacking for words. She's talking about her son, and then she's saying, "Hey, I'm basically going to hit, talk to my mom." And so as everybody says, she's got the soft tissue swelling. She's got the hit in the front and the back, in the front and the back. So if we could play that little clip there, Dave, this would be great. So this is just, there it is. So now we're starting to see there's the bleeds in the front, the white. There's the soft tissue in the back, right? Sitting back here is where she fell. And then, of course, there's just some blood in her ventricles there, which is normal. And then as we come back, no fractures or anything like this. So she's pretty good. So she's got a good subarachnoid hemorrhage. So here's the key point. So she's got some subarachnoid hemorrhage that's going on. There's no midline shift. So this is the big thing. There's no midline shift. So the ventricles aren't pushing up against each other. And so this is the best part. So she is what we'd consider, she's a stable subarachnoid hemorrhage at this moment. So now the question is, what do you want to do? So you've got the head CT, you got the subarachnoid hemorrhage. What do you want to do? And the key thing to this, guys, is just lowering her blood pressure. Because you see, as that blood's sitting up there in her head, as we keep that pressure high, it's like pipes in your house. Those pipes are, full of pressure. And so what it's going to do is leak more blood. And this is what we need to do, guys, is to stop the pressure. In other words, bring the pressure down. So now, of course, we can get into this discussion about what do you want to use to lower someone's blood pressure. We could use like the labetalol, we could use the hydroxyline, we could do some other meds and stuff like that. And usually with someone like this, we like to bring it down pretty quickly. And specifically, with someone like this would be like some people like the labetalol, because it takes care of the systolic and diastolic. Some people like the hydroxyline, but again, we need to slowly bring it down, and so she doesn't bleed anymore. Now, the next question is like, what do you want to do about the bleeding? Because she's on aspirin. So if you pull down the page here a little bit, Dave, if we can just pull the page down just a smidge here. So there's your EKG, and you're like, this is not helping me much. I mean, we could argue, she's got there's her heart rate. And now, after this time, so what do we got? 300, 150, 100, 75, 60. So, it's back down to normal, right? So there's your EKG. And then if we pull down a little bit farther there, Dave, what we'll see here is the question, the big
You just did something because you're experienced, but can you explain how you went?
Oh yeah, I'm sorry. I apologize, guys. So what I did is that you take a R wave, any R wave, right? So just pick any R wave. There you go, Dave. Pick that one. Pick one that's directly on a line. How about lead 1 and the second one? Or I'm sorry, no. Go down the rhythm lead, lead 2 on the bottom of the page, and pick that one, Dave. That's fine. There you go. So the next line is 300, 150.
We're talking about the rate.
Right, the rate, right? 150, 100, 75, and she's just right below 60. So there she is. So this is kind of like, what I thought in the beginning. Usually, when they first come in and get their initial vital signs, right? In other words, they're in pain or anxious and stuff like that, right? So that's how you figure out. So you find the R wave. Next line, okay, so we go, 300, 150, 100, 75, 60, and then some people think the next one's 40. We can get into that academic argument, but this is just a kind of a good ballpark way of doing it, right? And then, so here we are looking at her EKG, and it's like she's got a P QRST and a P and a QRS and a T, so she's doing pretty good, right? She's doing pretty good. So if we pull down the page just a little bit farther, if we go down, Dave, just a little bit farther, there we go. So now, so what do you want to do? So the question is that, you see, guys, this is like, I know you look at this case and you think, oh, this is simple, Joe. Just get a CT of the head and admit. What the real hidden thing here is this, is that, you see, guys, when people go syncopal or people have these subdural bleeds, what we have to or these they could have a subdural bleed, they could have, subarachnoid hemorrhage. It doesn't really matter. The question that we really are most worried about is what's below. So you see, guys, now, even though we have the diagnosis, now what we're going to end up doing is this MRI of the MRI and MRA of the brain and the neck. So let me help you guys out. The MRI is going to look at soft tissue. The MRA, which is an angiogram with an MRI, is now going to look at the blood vessels, which are soft tissue, and they're going to highlight it. So now they're going to look at the vessels. That's what the MRA of the brain and neck. So they're saying, hey, we're going to look at the soft tissue of your brain and neck. We're going to look at all the blood vessels. We're really going to light them up, and we're going to see who's got problems and who doesn't. So in other words, what we're really looking at is the pipes in your head and neck. That's what we're doing. This is a much more high-def test. And you're right, guys. You come to the emergency room, we have our code neuros or code strokes or whatever you guys call it in your emergency room. You're right. We're going to end up doing the CT angiogram because that's quick, fast, and I get the information right then and there. But with this one, since she had this bleed and she has hypertension, we're worried about what's below. So this is why you end up seeing these bleeds getting the MRI, MRA of brain and neck afterwards, because it's really later to obtain and see if she's got some type of like maybe some type of ischemic disease, maybe she's got some plaques, maybe she's got another aneurysm down there in the neck. So this is really why that workup doesn't end here. It goes one step farther. So that's the real key point to this, is that we're not done. And then the next question is like, so do you want to anticoagulate? In other words, she's on anticoagulants. Do you want to stop the anticoagulation? In other words, she's on aspirin. So does she really require an immediate platelet transfusion? Because remember, aspirin affects your platelets. It's an antiplatelet medication. That's what we say it is. So the question is like, do we need to do something to stop it? And that's the right question. And so when you look at these subarachnoid hemorrhages, most of the times they don't, guys. So according to what's called the patch trials, and this is just something for you guys to read, this is just basically telling us, okay, so how bad of a bleed is it? And do we need to reverse this immediately? And that's the thing that we're running into. So now, does everybody see, this is a simple case in the sense that, yeah, I'm going to do a CT and EKG ASAP. But does everybody understand, just because you have your diagnosis of a subarachnoid hemorrhage, are you done? Oh, no, no, no. There's so much more here. I got to now do the MRI of the brain, and now I need to do the MRI, MRA, and then I need to really work this lady up. And why is her blood pressure so poor? And I think Dave was right in the sense that, talking about maybe this patient's poorly compliant. I think we've all seen that in our clinical practice, right? That patients aren't the most compliant individuals with their medications, even though we hope they are. Do you have any comments, Dave?
I don't. I'm curious if any of the learners have any, or attendees have any comments or questions about this case before we move on to the next one. I think this is a great case. For me, my teaching points are exactly what you said. I think that this patient seems altered. Clearly, for me, pay attention to the vital signs. The EKG is more consistent with a patient that's A, on a blocker, beta blocker, B, perhaps with an intracranial bleed. And with the elderly, you're worrying about head bleeds because it's common. It's a common thing to present. So these are the things that I typically would consider as summary teaching points that I've learned from this, thanks to your great teaching. But I'm curious if anyone has any other questions. Maria, you want to discuss the second point? Can you be a little bit more clear about what you mean by the second point? Do you mean the 15 to 20% of patients with spontaneous subarachnoid hemorrhage are found to have non-aneurysmal SAH? Is that what you mean? Or are you talking about something else? But while we're doing that, I can perhaps go to the next case. So Joe, what is the next case?
It's 121.
Great.
That's it.
Well, this is one of my favorite cases. Yes, so I think she wanted to discuss the issue around subarachnoid hemorrhage. Joe, did you want to talk a little bit about that?
Yeah, I'm sorry, Maria. Could you be can you discuss this? Yes. Okay, so it's about the subarachnoid hemorrhages, right? So you'll see one of the things about the subarachnoid hemorrhages is that we think that sometimes they are due to little aneurysms that kind of, that do get ruptured, and this is true. And what you'll see, guys, in the real world when you get out in the real world is this. So you're going to end up doing an MRI or an MRA of brain and neck, and let's just say, I don't know, maybe you're working up an elderly person who, I don't know, they got syncopal, they were at the birthday party at a restaurant. And so you were the good clinician and you ordered all that right stuff. And then comes back the reading that this person has a small aneurysm located at, some part of the brain. So you see, one of the things you're going to run into, so what do you do with that finding? What do you do with this aneurysm that hasn't ruptured? In other words, AKA, you don't want him to become a subarachnoid hemorrhage. So this is where intervention radiology makes their money, right? This is kind of like, I would say, this is where intervention radiology makes their money, and they decide, okay, does this need to be coiled, yes or no? In other words, does this need to be addressed? One of the things we're finding out, this is just as, this is science, guys, right? As we go through life, we get more data, better, better assessments. And so we do see that we can get these spontaneous ruptures of these small things, but then at the same token too, we can see subarachnoid hemorrhages from just basically people getting head injuries and blood thinners. And so it becomes this really ambiguous answer. I know I sound like a politician because I'm not giving you a true answer, but this is the whole point to it, Maria, is that, in other words, it's one of those things where, can I get it from a head injury? Yes. Can I get it from a non-aneurysm just vessel deciding to rupture? Yes, I can. Can I get it from an aneurysm that rupture? Yes. So you see what I'm saying? So there's a lot of etiologies to this. It's not just a aneurysm. For example, like your diabetics, right? This is what we're getting ready to go into, but like your diabetics, right? I always say, diabetes, they get that microvascular injuries to their blood vessels. So now can everybody picture a small vessel in your head? I got diabetes out of control. I'm hypertensive, and that small blood vessel that I'm damaging now ruptures. And so there you are with the subarachnoid hemorrhage, or it closes off. Well, there's your ischemic stroke. So does everybody see the bigger picture? This is what I'm trying to get inside your head, is the bigger picture of this. And like I said, this is what this is all about. It's just giving you guys an idea of like, hey, I need to work this up. I need to look around. Because if there's any if there's any advice I can give you guys after my 37 years in the ER, and I wish I could, I always say, like, if there's any gift I could give the world, you know what it is, guys? I like to take all my memories of everything I've done in my 37 years and put it in a USB port, and then be able to download it onto your head. Sort of like, you know how Neo learns how to fly a helicopter in the Matrix, sort of like that. I wish I could download it onto your head. And if I could, you would see what I'm saying, in the sense that, yeah, let's work this up. It looks like a subarachnoid hemorrhage, yeah, but let's work this up. And that's the take-home message, Maria. That's all. In other words, there are other etiologies to this, but great question, great question, great question.
Okay, so we are on to the second case, and we have just a little bit less than 20 minutes. So we'll kind of get through this one pretty quickly because we want to end on time. So with that, Joe, are you okay if I hit play?
Yep. Let's fire away.
Just want to stop it so everyone sees that. I think what we're talking about is this hyperpigmentation, but let me continue.
How long have you been trying to lose weight?
For about 2 months.
Okay. And do you have a family history of diabetes?
Yes, I do.
And what's his blood pressure?
130/90.
Right.
All right, guys. So hopefully everybody got to saw the dark spots on his neck, right? Those hyperpigmented skin on his neck. So let's just take a look at, who the patient is, right? So he's a 19-year-old male. He weighs 363 pounds at 164.7 kilograms at a weight of about, a height of about, 70.5 inches or 179.1 centimeters. So if you look that up, guys, as a BMI, he's over 50, right? So we can all agree, based upon his weight parameters and height parameters, that he's in the morbid obesity category. So they did the blood pressure, right? So he's a little, right? So he's hypertensive, and I think, Dave would back me up on this one specifically, when we're dealing with younger adults. So a lot of times with these obese people, the big people, you got to make sure you have the right blood pressure cuff. That's a big take-home message I've learned, guys, is that if you don't have the right cuff, In other words, let's say you have too small of a cuff on a person who's overweight. What will happen is this, guys, is that the reading will be high. You get it? The reading will be high. So in other words, you got to make sure that the cuff is at the right size. So let's just say you have a smaller cuff than what than what is necessary. What's it going to do? It's going to give you a false positive. It's going to tell you that it's too high when actually it might be just quite a normal blood pressure in this individual. So that's actually, if there's any take-home message to this picture, is getting the right cuff. And so you'll see if you come to work with me, we have cuffs, different sizes, and hopefully, I'm sure at your clinic or wherever you guys practice, you have different cuff sizes, but you'll see that cuff size actually has a lot to do with blood pressures, right? And I know in Dave's world, in the pediatric world, that's a huge thing. It's having the right cuff. And it's the same thing in our world, in the adult world. It's the same thing. It's having the right cuff. So I think this is kind of a take home message to this one here is that, this individual, right? I mean, that cuff's a little bit, it has just a little bit layover, but it's almost like it's just a smidge small. You're kind of looking at this going, it's barely covering, right? So just food for thought. When we take blood pressures on people who are large, we need to make sure that the whole thing covers there. So if we could pull that screen down, Dave, that'd be peach here, my friend. And so now he's got these dark increases in the neck folds. So now you're thinking, okay, so does he have nigrogans? Is it Addison's? Is it pellagra? Is it hypertension? Is it diabetes? Right? So what do you think? And so I think most of us can look at this and think like, okay, so what do you guys think from a diagnosis point of view? So here's your morbidly obese 19-year-old. Here's your differential diagnosis. And like you said in the story, when the provider was talking to this individual, they said, yes, I have a family history of diabetes. So what does everybody think? So just give this some thought, right? Just give this some thought. And anybody in the question and answer, go ahead. You get to pick one of those, not all of them. So just pick one of those. Pick one of those five. So do you think it's right? So do you think, in other words, what do you think he really is? So in other words, not that I want to talk about the nigrogans. I want to know, that's the smoke. I want to talk about the fire. Where's it coming from? So what do you guys think?
So Joe, while we're asking some of our attendees to respond, I'm curious, your practice setting is the emergency department.
Correct.
And I'm assuming that you see a fair amount of obesity come in.
Yes.
And
Yes.
There's a different approach. I'm an ER doc, but I used to be a pediatrician. There's clearly
Right.
a different approach and a focus. I mean, part of what we're trying to do is figure out emergencies and manage acute issues as opposed to
Sure.
chronic issues. But obesity is such a large problem in the United States, and I'm curious if you how you approach that, and do you talk about obesity in the setting of the ER?
Yeah, so usually what we do, so we're lucky enough that we've got some great outpatient resources is what we do, right? So we kind of let them know like, okay, listen, just based upon the parameters, this is where you're going. And specifically you have someone with new onset diabetes, right? So you try to get them in the right, right setting. In other words, it's going to take a lot, guys. I always say like when people get this, unfortunately get to this point, it's going to take a long time to get them out, but you got to give them the right resources. So we deal with this a lot in the ER. So what we do is we have like these resources, we have these clinics we can send them to. And then of course we got the nutritionists we can send them to. And so it's like, I always say like when it comes to obesity, guys, I know this sounds funny, but it takes a village to get the person out. In other words, it takes a lot of different players to help this individual, to help them out. In other words, you're going to take an endocrinologist, to tune up, their metformin and all their diabetes medication. It's going to take a nutritionist, to help them out. We haven't even gone into the mental health issues, what that is, right? And so it takes a lot of people. So usually we're pretty lucky at my job. We've got some really great outpatient resources that we send them to, and they tend to do really, really well. So as long as they keep to the game plan, these people tend to do pretty well. So Adriana is 100% completely correct. It is type 2 it's full-blown diabetes. I totally agree with you, Adriana. She is 100% completely correct. So that's exactly what this individual has, is full-blown diabetes. So Dave, if you can get down to the down to the standard of care, that would be the big one actually. So now the key point. So what do you want to do with this guy? Right. So that's the right question. And that's why I bring out this case. Not that it's so easy, but it's actually so complicated. So you see, what do you want to do with your new onset diabetes? So I always say with our new onset diabetics, right? So I always say, who's the driver in the car? That's metformin. So metformin is your driver. The question is that you can add passengers. In other words, you could use the glypride, Actos, Januvia, things like that. But remember, they tend to be passengers, not drivers. That's I kind of make the analogy of that. So in other words, metformin is going to be my go-to med. And so what's this guy getting first day out? Metformin. What would you like to do with them? Hemoglobin A1C. But you see, here's the key point. And this is the thing I'm really trying to hammer home on this case. You see, guys, he's 19. He's got morbid obesity. He's a diabetic. And can we all agree this is not going to play out well 20 years from now? So you see, we can do something. He's young. We can actually get in here and actually do something. We can actually, increase the longevity of his life, right? So I can actually do something with this guy. So what is he going to need? Well, he's going to need all hands on deck. So what would you like to do? Well, let's start him on the metformin, ASAP. What would I like to do? I'd like to get him in a nutritional, or a fitness program. In this 5-2-1, they talk about 5 fruits. This is what they're talking about. So if you look 5-2-1-0, you'll talk about this is what they're talking about, right? And then you want to slowly get him on the glide slope down, right? So you'll see these kind of diet fads where you can lose 10 pounds in a week. That's completely unhealthy. It's like slow. Let's get them down, like a nice slow glide slope, right? I always say, it's like landing a 757, right? This is a big plane. How do you want to land it? With a slow glide slope. I don't want to nosedive it. I want a slow glide slope. And that's what I always say. And you'll see if you look at the scientific studies, that's what works. So to keep weight loss off permanently, it's slow. It's not dramatic. So with this young guy, what would you like to do? I'm going to give him the metformin. I'm going to give him the right resources to help him with nutrition and fitness. 3 pounds a week. This is great. This is like, give this guy a gold medal. That's great, great work. But the more important thing, he's 19. You see, guys, that's the take home message. When I'm dealing with my obese teenagers, these are the ones you really want to go after. Because you see, now you're talking about increasing their longevity. Because we all agree, what's the number one killer of diabetes, guys? Okay, they go into renal failure. If you don't believe me, walk into your dialysis center tomorrow. Just walk in there and say, hey, who's a diabetic? Whole place will stand up. You're right. There's some outliers. There's some polycystic kidney disease, and there's some lupus people here. And that is true. But 90% of them, diabetes. And then we're not even got into the strokes, heart attacks, right? All the vascular issues, losing limbs and things like that. So really, that was my point to all this. You have a young, healthy 19-year-old male who's got the skin changes telling you, I got full-blown type 2 diabetes. What does he need? Everything. In other words, he needs the full court press. Because you see, now we can actually increase his longevity. Not saying you can't help a 50 or 60-year-old with type 2 diabetes. But what I'm trying to share with you is that we'll be able to add more years to his life than we could maybe possibly do with someone who's older, who's had it for a much longer period of time. And that's the take-home message to this here. So Dave, you got any other inputs here? Please fire away, my friend.
I actually am struck. This is a primary care setting, so everyone's clear. This is not an emergency room. This is a primary care setting, and I used to be a pediatrician in a primary care setting, and now I'm only in the peds ER. I have a lot of compassion for these patients, and when I see someone who has an interest in trying to change their behavior, I try to be very positive about it. And the reason why is I think what you pay attention to grows. And if a patient is willing to change, I want to be on their team, and I want to be supportive of them emotionally, and for them to know that I'm in their corner and do whatever they can. Because for a 17-year-old to be sitting, a 19-year-old to be sitting at 363 pounds, that is a very bad progression. And this patient, the type 2 diabetes and hypertension is just the start. And I'm sure Joe then sees later on, when they're in their 30s, they have their first MI. And they have, significant atherosclerosis, and they have other issues all related to obesity, and we call it metabolic syndrome, where you develop these other things that come along with obesity. So I think it's an approach that is different. I tend, as a pediatric ER doctor, to not talk about prevention and really bring up the obesity piece, because I don't have that established relationship with the family. But it's the big elephant in the room, frankly. And I think that my feeling is that if they're not, the biggest thing I can do if they're not connected with a primary care doctor, I would get them out into making sure that they have really good primary care follow-up. I think Joe can probably attest that one of the things that we do as ER docs is we're dispositionists. And one of those dispositions when they go home is to make sure that they get good follow-up with their primary care provider, because that primary care providers can manage 90-95% plus of what oftentimes just shows up in the ER. And the big issue here, it's not the hypertension. The big issue is not the nigricans. The big issue is really addressing his morbid obesity. And frankly, I have a massive amount of compassion for these patients. I think it's hard. And I want to do whatever I can in my role as an ER doc to support these patients, their families, to getting help. And as Joe was alluding to, exercise is really important, but I think the focus has to be on nutrition and getting patients on a good program where they're eating well and they're not hyper eating and not in that positive bad cycle or negative cycling of eating poor, gaining weight, eating poor, gaining weight. And so I don't know, Joe, if you have any other thoughts.
Yeah, no, I think you hit the nail on the head there, Dave, 100%. Because literally, I think it was like 2 weeks ago, 3 weeks ago. I think it was about 2 weeks, 3 weeks ago. I had a guy he was 29 years old and diabetic, been a diabetic since he was 15, and he had a big LAD guy, so he had the widowmaker at that young of an age, and so he went to the cath lab. I mean, he's fine, he's going to live. But, I can only tell you, like, when I started back in 1984, if you would have told me that I'd be seeing a 20-year-old with an MI, I'd be like, you got to be kidding me. But today, if you come to work with me, later on tonight, this is, I don't want to say this is the norm, but this is where things have evolved too. And I agree. See, the key point to this case is like, help them as much as you can, because they're going to need a lot of help, right? And then I would say, like, get to know. What I've learned is I've gotten to know my resources, right? So I've gotten, like, it's like, you'd be surprised, like, you're going to laugh. Here in Newport Beach, there's this nutritionist who, and that's all she does is work with obese people. And so I actually walked into her office one day and talked to her and said, hey, my name's Joe. I work in the ER down the street. You got any pamphlets? And well, she and I have actually become best of friends. And so I'm always like, when I have patients that come in and need help, I have one of her pamphlets going, hey, here's a nutritionist that works, solely with obese people. She's great. She'll work with you. And so I've learned that a lot of times when you get to know your resources around your community, this is the best thing for these individuals. So as you can see, it's a simple case, but it's very complicated, right? It's very, very complicated, right? And we haven't even touched the mental health disorders. And I think Dave's right. I mean, this is like a whole lot of things that we have to do to help these individuals. So that's kind of the take home message. So if I had to say, like, there's any take home message to all this, because I think, right, we only got about 5 more minutes left. I think the take home message to all this is that in the first case, all I care that you walk away from is that altered mental status, scan them. We're going to follow it up with an MRI, MRA. And then the other take home message I wanted you to get on that first case is this. If I'm on a blood thinner and I get a head injury, you see, guys, you can run into this argument about people say, well, they don't meet the Perkin criteria for CT scan, or they don't meet the Canadian CT head scan, criteria. And that may be true. But one of the things you'll learn is that as soon as you're on a blood thinner and you get a head injury, you are most obligated to get a CT scan. You're right. We could sit here and play the criteria game with blood thinners. But one of the things you'll learn, guys, is that this may be what some people would say, well, we could argue that, my Canadian CT scan rule, dictates, to scan them or not. Just yours truly, just a piece of me that you probably don't know. I do Medi-Mal cases on the defensive side. And one of the things you'll see come across my table all the time is a head injury, blood thinner, no scan. And trust me, guys, these things all get settled out of court. and then you get dinged for it. So what I've always tell people to do, you have someone who's on a blood thinner, scan them. No one's going to snicker at you. You're right. We can argue about the criteria. You're 100% completely correct. But just as a CYA maneuver, oh gosh, scan them. And then on the second case here, the take-home message that you know, kind of just to circle this, to put a big circle around this, it's like young, obese, type 2 diabetic. What do you want to do? Everything. I want to do everything I can for this guy or girl, right? I want to do everything I can. I need all hands on deck. Yes, hemoglobin A1C. Yes, let's start them on the metformin. Yes, let's get them a nutritionist. You know, yes, you know, let's get them in some type of exercise program. In other words, help them as much as possible because they need help. And like I said, we didn't even touch the mental health issues, and that's a whole nother cascade of things that we know that they'll need help with. So at the end of the day, these are the patients that actually need the most help because we can change their life. You get it? We can actually do something really, really good. So that's kind of the take-home messages that I've learned. That's why I picked these two cases here, guys, because there's just so much there, you know, that will help you in your, you know, future medical careers as you guys go down this journey and everything there. Do you have anything else you'd like to add there, Dave?
No, I'm appreciative of our attendees today. You all were great in participating. I want to thank Joe Gilboy so much for his time and efforts as an educator, an experienced clinician, giving his key points and words of wisdom. I hope that you all enjoyed this hour together. I always learn a lot from Joe, and I learned a lot from reviewing these cases. And please reach out to us if you have any other questions. And we'll be continuing this ReelDx Classroom series on a monthly basis. And I hope you all have a great rest of the day. I also, again, want to thank Point of Care Network and Smarty Pants for their support as co-partners in bringing this presentation to us. So hope you all have a great rest of the day. Bye-bye.